Next presentation, and it's from Professor Kimura, Absorb Japan, 12-month clinical and 13-month angiographic outcomes from a randomized trial evaluating Absorb Bioresorbable Vascular Scaffold versus metallic drug-eluting stent.
Thank you very much. Good morning, ladies and gentlemen. It's my great pleasure. Okay, thank you very much to present the Absorb Japan trial result in this press conference. This is my disclosure for Absorb Vascular. Theoretically, bioresorbable vascular scaffolds, BVS, may overcome the shortcomings of permanent metallic prostheses. However, whether BVS are as safe and effective as metallic DES prior to complete bioresorption is currently unknown. Therefore, a randomized control trial comparing the clinical and angiographic outcomes of BVS with those of Xience cobalt chromium drug-eluting stents was designed to support regulatory approval of the Absorb BVS in Japan. The Absorb Japan is a prospective randomized active control single-blind non-inferiority multi-center Japanese study. The inclusion and exclusion criteria was typical for the pivotal studies of drug-eluting stents for approval. Patients were randomized in a 2-to-1 ratio, either to BVS or cobalt chromium EES. The primary clinical endpoint of the study was target lesion failure at 12 months. The major secondary angiographic endpoint was in-segment rate lumen loss at 13 months. Between April and December 2013, 400 patients were enrolled and randomized either to BVS 266 patients or cobalt chromium EES 134 patients. 12 months clinical follow-up was completed in 99.7%, and 13 months angiographic follow-up was qualified for quantitative angiographic analysis in 95%. Baseline patient characteristics were very comparable between the two groups. The mean age was 67 years, and 36% of patients had diabetes. The majority of patients had stable coronary artery disease. Device success and procedural success were both very high and not different between the two groups. However, the procedure duration was significantly longer with BVS as compared with cobalt chromium EES, 50 minutes versus 45 minutes. Despite the similar final expected balloon size, in-device MLD post-procedure was significantly smaller in the BVS group as compared with the EES group, 2.43 millimeter versus 2.64 millimeter. However, post-procedure in-segment MLD was not different between the two groups, 2.20 versus 2.27. This is the primary endpoint result. The primary endpoint of 12 months target lesion failure occurred in 4.2% in the BVS group and 3.8% in the EES group. The upper 95% confidence limit of the difference was 3.95%, which was lower than the pre-specified non-inferiority margin of 8.6%. Therefore, BVS was non-inferior to EES in terms of 12 months target lesion failure. The cumulative incidences of the individual components of the primary composite endpoint were also not different between the two groups. No cardiac deaths in both groups. Target vessel MI 3.4% in the BVS group, 2.3% in the EES group. Ischemia-driven target lesion revascularization, 2.6% in the BVS group versus 2.3% in the EES group, not significantly different between the two groups. If we look at the cumulative incidence of 12 months definite or probable stent scaffold thrombosis, it was 1.5% in both groups. If we look at the angiographic outcome, the major secondary angiographic endpoint of 13 months in segment rate lumen loss was 0.13 millimeter in the BVS group and 0.12 millimeter in the EES group. That the upper 95% confidence limit of the difference was 0.07 millimeter, which was smaller than the predefined margin of 0.195 millimeter. Therefore, BVS was non-inferior to EES in terms of 13 months in segment lumen loss. Furthermore, 13 months follow-up in segment MLD, which is a relevant surrogate for the clinical restenosis, was also not different between the two groups, 2.08 millimeter in the BVS group and 2.15 millimeter in the EES group. There were several important limitations in the present study. The non-inferiority margin of the primary clinical endpoint of this study was relatively large, particularly with event rate lower than anticipated. However, Absorb Japan was designed to support regulatory approval of the Absorb BVS in Japan. The Japanese regulatory agency requested a clinical primary endpoint and agreed to a relatively large non-inferiority margin to keep the study sample size reasonable. Although TLF rates of both BVS and EES were lower than the anticipated rate of 9%, the observed 0.39% difference suggests that the two devices are similar. Second, the study was clearly underpowered to evaluate the low-frequency events, such as scaffold stent thrombosis. And finally, inclusion of a highly selected patient population. The study provides data for a patient population typical of pivotal studies for approval. Data in broader patient populations will be studied in subsequent trials. Despite these study limitations, we would conclude that in the Absorb Japan trial, BVS demonstrated a similar midterm clinical safety and efficacy profile as cobalt chromium EES with comparable 13 months angiographic outcomes. These positive results lay a solid foundation for continued evaluation of long-term outcomes in patients undergoing percutaneous coronary intervention with Absorb BVS. The Absorb Japan is published online today in the European Heart Journal. Thank you very much for your kind attention.
Thank you, Professor Kimura. Questions?
My name is Hashimoto from Tecros News, and I have a question regarding this outstanding study. And my first question is, what is ideal adaptive duration for BVS?
The protocol dictated 1 year DAPT, and actual compliance was 97% in both, 97% in the BVS group and 95% in the ES group.
Okay, and my other question is, having you received approval for third generation drug-eluting stents, such as Archimaster from Terumo, and how do you differentiate the use of this product as compared to third generation drug-eluting stents?
The differentiation between BVS and third generation DS, right, yeah. We couldn't find out any meaningful difference between the second and third generation DS, so the current study message will be also applicable for the comparison of BVS and third generation DS.
Thank you very much.
Thank you.
Axel Viola, Intervention Lab Germany. Maybe I have a question to Dr. Kimura and Dr. Serois. If you are talking to doctors who are not involved in registers or studies on Absorb, they not seldom describe problems with thrombus building and something like this. Can you comment this maybe?
Okay, actually this trial is clearly underpowered to show the stent scaffold thrombosis rate. So we should wait until TCT, because in the TCT, Absorb US trial enrolling 2,000 patients, and the Absorb China enrolling 80 patients. So altogether, we will have 3,400 patients to have certain message regarding the difference in the thrombosis between scaffold and metallic DS.
Add something is that as I mentioned, these struts thickness are quite large, 150 micron. So you have on the top of the struts a high shear stress, which can activate the von Willebrand fibrinogen and so. And then behind the struts, you have a low shear stress, even with reversal of the flow in a region where there is no nitroxide, TPA, or prostacyclin. So it's clear that the first 30 days is somewhat critical, and in the GHOST registry there have been a clustering of the thrombose in that period. So we have probably to, first we are working on reducing the thickness of the struts, and secondly maybe to apply more contemporary antiplatelet drugs such ticagrelor, prasugrel.
Lynn Peterson with Trends in Medicine. So Dr. Kimura and Dr. Sirois, so the rationale for the bioabsorbable stents beyond being able to MRI a patient, if we're getting comparable results, is there any, are there any other advantages?
Yeah, I think you're right. This is a technology which starts on a basis of non-inferiority at 1 year, so you can ask yourself what is the gain for our patient. I think we believe, and we have long-term follow-up in a small cohort, that with full bioabsorption of the polymer, the fact that we use the term uncage the vessel, allowing late remodeling, allowing shear stress, allowing cyclic strain, I think will be favorable for the general metabolism of the vessel wall of the vessel. So the expectation, or at least the promised land, is that around 2-3 years we may see a difference in clinical event, because as you know, even a best in class like the science, we see the late loss increasing with time. It starts with 0.10 at 6 months, and then 0.23 at 1 year, and then 0.33 at 2 years. We don't have data of 3 years. So that's what we want to avoid, because you will have the possibility to have this late lumen enlargement.
Okay, thank you.
If I
And
could
as
just,
Professor
could I
Kimura
just
said,
follow up on that for just
sorry?
a sec? Could I just follow up on that answer for briefly? The late loss with the bioabsorbable was higher, so you're starting at a higher space. Will that go down, or I mean,
Yeah, that's
potentially
correct.
could it be worse?
Yeah, that's correct. But this late loss is absolutely subclinical. You know, the 0.10 or 0.20 is not an issue. But what is important is to see 2, 3, 4, 5 years down the road, what is the evolution of these late loss in the cage structures versus an absence of cage.
So as Professor Kimura says, we need the results of the larger, longer-term outcome trials. I think we better move forward.